the top of the foot more efficiently and reduces pressure under the hallux by around 30%. Okay, so again, fits really nicely, and for mine it's a lifesaver for these type of shoes because it at least is something that can accommodate that type of footwear. We have a device targeting a diabetic foot, and then we also have the last two devices which are heavily driven towards a few interesting concepts. This product in particular for mine is the most exciting product we have in the whole range. This is a device specifically targeting a supinated foot. Now, a supinated foot obviously is going to have a lot of differences in terms of the way that the structure is put together. In the rear foot, g'day, how are we going? The rear foot, we have no posting in the rear foot with this one, so it's just got a nice deep heel cup. We have on the lateral aspect, or the outside, we have a little notch here for the fifth metatarsal, which tends to adduct in the forefoot. We also have, from a forefoot perspective, a 6-degree wedge on the lateral side, and we've taken into account the fact that the forefoot lies more plantarflex to the rear foot, or a forefoot equinus generally tends to be in existence with a supinated foot. They actually come with an 8mm heel raise as well to help balance the device out in a shoe which was flatter. The more elevated the shoe, the less of the need for the heel raise, because it'll actually negate the forefoot movement as such by doing that. If it sits flat, the foot's going to be more likely to rotate laterally.
So you actually have the calcaneus flat, but then the forefoot is actually with the angle.
The forefoot's got the angle in it.
The other way, right?
That's correct, yeah. So because of the fact the rear foot really doesn't have a great ability to actually evert properly, where we provide that motion is through the MLA, so we actually have softened under the arch contour and provided the forefoot posting so that we can get the foot moving and actually unloading. The first MPJ also lies plantarflexed, so we provide a softer piece under the first met and effectively just balances out the second through to fifth. So it's an ingenious little product. Like I said, I guess it's a very tricky foot to deal with in general. Tends to be... It does, yeah. This one comes with an 8mm heel raise that you can apply to it. Like I said, depending on the elevation of the shoe, I'll send a link that actually has an 8-minute presentation by Brian Hoke on evaluating the supinated foot, which is really simplistic as well. But I guess essentially it's driving the foot to pronate. With a foot that really doesn't pronate enough by itself, it underpronates. And then this is the last device here, which is our tissue stress relief insert. So some of the key components to this and the research that was driven behind this, Tom McPaul's research was really based around reducing tissue depression, so more efficiently spreading the load of the foot across the breadth of the foot itself. So it's got a softer top cover, as you mentioned before, so I think most of you have had a bit of a feel of this, so it feels quite soft underneath the foot, but a higher arch contour. So essentially what it does is by using a middle density, it still allows the foot to pronate, but you've got better contact with the profile of the device while the foot moves through mid-stance into toe-off. So for someone that had a midfoot that collapses a lot, and Iggy's got one of those type of feet where his whole midfoot tends to collapse, this will actually control and contour to the midfoot a bit more effectively. One of the big problems with a higher arch profile tends to be it feels quite uncomfortable, whereas using a softer material means that you actually get better comfort out of this. So it's specifically driven towards anterior knee pain, plantar fasciitis, tibialis posterior dysfunction. So there's a few dysfunctional issues that it's targeted at, but is going to address the midfoot a little bit more effectively. Okay, so that's these devices. So I guess essentially within the range here, there's some use in the majority of them. The Vasily Dannenberg and the Vasily Pryor device are probably the two which I would find as day-to-day products that are the most easy to be able to work with. And then obviously on a case-by-case basis, the supinated foot device can provide some good benefit as well. So from an assessment perspective as such, I just want to go through some really basic assessments. This is a new world record for me as well. I'm getting through this as quickly as I have done. So just having a look at the foot, we want to have a look at some of the functional divisions of the foot itself. In the rear foot, the calcaneus and talus obviously, and rear foot assessment and rear foot function tend to be a primary sort of aspect of most foot related assessments, but I'm pretty keyed into being able to make sure we don't lose track of the fact that we need to look at the midfoot and we really need to look at the forefoot as well. Even when we went through a few basic concepts with Iggy's feet before, he has some real issues when it comes to the forefoot, so we need to make sure we're addressing those. So essentially with this here, the rear foot and the subtalar joint, we want to be able to provide some support and control through that area. The midfoot as such, obviously the way that the midfoot moves, it moves in a relatively similar way, but obviously works in conjunction with the rear foot, and then the first MPJ, certainly from a functional perspective. If we're talking about range of motion as an example, you're looking at about 65 to 80 degree range of the first MPJ, rear foot around 18 to 20 degrees. So if we're not addressing the forefoot effectively, we might lose a big functional aspect of how the foot actually moves mechanically. Okay? So from a reference perspective, I'm sure you've worked with cardinal planes in some capacity, probably or hopefully on a day-to-day basis, I would think. So this shouldn't be anything brand new for you. I guess when I'm thinking about cardinal planes, I like to break things down even more so. I use a car and functions of a car to be able to trick my brain into rethinking about what each of these functions are about. So if we're talking sagittal plane function, what function in the car best represents sagittal plane function? Excellent, you're spot on. Wheels. So the wheels in the car. Okay. If we're talking frontal plane, what's the easiest representation on a car of frontal plane motion? Windscreen wipers. If we're talking transverse plane motion, opening and shutting the door. Okay? So from a foot perspective as such, the rear foot moves through triplanar motion, the midfoot and the forefoot all move through triplanar motion. So certainly from a motion perspective, when it comes to assessing the foot, we want to be able to take all of those aspects into account as well. And that comes to when you're assessing range of motion, varying other different things, making sure you're working with the appropriate plane to assess the foot properly as well. So this just gives a little bit more of a picture. We sort of mentioned this earlier as such in terms of motion through each of the body parts. Pronation is comprised of dorsiflexion, abduction and eversion. Supination, plantar flexion, adduction and inversion as such. So it's a totally different process that goes into both. This gives a pretty good picture of what a pronated foot is generally going to look like as it approaches the ground as such. And Iggy's feet will give us a good representation of this in just a moment. So we need to keep these in mind, making sure that we're working within the appropriate planes. In terms of phases of the gait cycle, what phase generally would you suggest that most of the problems occur in?
Getting into all of it, but it's mid-stance when you're hitting it and everything's rolling in.
Yeah, mid-stance is generally going to be where most of the problems start to occur as such. As the foot's flat to the ground, the foot's moving from a mobile position to a rigid position, that's generally where most of the dysfunction occurs, and that's also when the primary amount of compensation is occurring as well. So if you haven't got a good strong structure in the foot, it's certainly going to take some of the other body parts to be able to continue to drag you through gait effectively. So if we can get the foot in a position where it's functioning a bit more efficiently, it does help out the rest of the body along the line there. Okay? So a really basic evaluation, basically what I've put together here is a few questions that might be asked. I actually put a form together. If you want to take one and pass it along, you can have a little bit of a look-see here. This is something that I discussed with the chiropractic assistants yesterday. I actually think it's something that could be almost promoted from their end to be able to provide to the patient, and then when they actually come to see you, hopefully most of these questions have been asked, and it may just give you another little bit of an idea about sort of what is occurring, if there is any foot-related problems that are actually occurring with the patient. It's pretty comprehensive. So it definitely goes into the time of day, how long, what activities, whether there's been any previous history of pain, so on and so forth. So, and definitely from a starting point perspective, I guess the information itself is something that you could quickly refer to. So hopefully we'll be able to work out a method of being able to implement something like this. It doesn't need to necessarily be as comprehensive as this. You might want to cut this to pieces and say, we want to have this question, this question and this question answered. But I guess this can at least give you a bit of a starting template. It actually has been driven, there's a clinical or there's a case study which has been done with patient history that I was able to research, so foot and ankle patient history and being able to take it more effectively. So I'll send you a copy of that paper to have a look at as well, which is quite interesting, and this was the best way to be able to get the most appropriate information from the patient rather than just yes/no questions and answers. Okay? So let's have a basic assessment of the foot. I've got a few different little assessment techniques that we want to bring in just to be able to have a look at what's happening from a foot positional perspective. Certainly On top of this, obviously, we would look at range of motion and see whether there's any restrictions in range of motion. But I think really when we're looking to evaluate the foot, even without assessing range of motion, you can get a pretty good picture of whether a foot is in a functional or a dysfunctional position. So I'm going to use Iggy again because he has terrible feet, and I've done some drawing on his feet already. So we've pre-planned him.
Good for a presentation.
You are good for a presentation, my friend. So if you guys want to jump, for those who can't see, you want to have a bit of a look here. Okay. So with this assessment guide, how I've gauged this is actually scoring the foot from -1 to +1. So -1 would be a supinated foot, +1 would be a pronated foot, and 0 would be a neutral foot. Okay. So when looking at the subtalar joint positioning as such, firstly we want to have a reference point for where a subtalar neutral position is. The easiest way to do this for mine is to palpate the head of the talus on both sides, on the medial and lateral side, and in a neutral position we should be able to feel an equal congruency on both sides. So you should feel the same indentation on the inside as opposed to the outside of the foot. If the foot is excessively pronated, we'll tend to find that there's a lot more pressure on the medial aspect as opposed to the lateral aspect. If it's excessively supinated, it'll be exactly the opposite to that. So we're looking at the talus positioning over the top of the calcaneus here more than anything else. Okay, and this particular sort of assessment is something that is done by hand, so you can actually feel very quickly whether there is pressure on the medial and lateral aspects. So if anyone wants to have a quick feel of Iggy's feet here, please, you're most welcome to do so. If he relaxes, I would score that foot as a 1, okay? Because it's more excessive on the medial aspect as opposed to the lateral aspect, okay? So that's the first assessment. So we tick him off as a 1. The evaluation sheet that I've got here has actually got another 5 or 6 evaluations associated with it. So, but I think really some of them tend to just get a little bit mixed and matched, and I think really what I'm trying to address with what we've put together for you, and I'd actually tweak it so that we'll have a particular sheet that's more effectively focused here, is just having these 4 assessments. So calcaneal position would be the second. So looking at the rear foot, and really we're looking to see whether it's more inverted or everted. So from an inversion and eversion perspective, pronated we would consider anything which is from a +5, neutral would be 0, and obviously when we're looking at a supinated foot, anything below 0 is going to lead us to at least seeing we've got a foot that is calcaneally inverted as such. So there's varying different ways to have a look at this. Obviously subjectively we can look. I actually like to use a bit of measurement. My father was a civil engineer, so he likes angles, so therefore I like angles as well. Phone can actually give you a goniometer, so it's the compass application. So if you use the compass application, just want to make sure that I've got this sitting level. Straighten this out. Maybe I need to recalibrate it again. Once I can get it sitting level. Oh, it's a slowing of the process. Come on, little machine. Let's go out of the app and go back into it again. Apologies for this, it should be done a little bit quicker than this. Making sure you have all your tools ready is a good starting point. I just want to calibrate it again. Okay. Alright, so from a positioning perspective here with Iggy, we look at the very top marker and the bottom marker. We're looking at around -6. If we put the foot back into a neutral position, that should take that from 0 to -6. Just on -1 there. So he starts in a position which is already in an everted position as such. So -1 to -6 would sit you in 5, which I would assess that to being in a more pronated position. If we do the opposite foot, we'll actually start you in neutral position. So let's externally rotate. Yep. Okay. Now this, again, this is just a reference point. Let's rotate that again. Yep. Relax. Okay. So less motion in the opposite side of the foot's probably better than doing on this side here. So -2, -1, -2. So the right foot is a little bit more everted than the left foot. Okay, if we're looking at the 2 feet. So generally around 5 degrees and above, you would consider the foot to be excessively pronated in the rear foot. So Iggy's right foot falls into that category. His left foot is between 0 and 5, so it's still pronated, but it's not in an excessively pronated position. So I'd score his left foot as a 0 and I'd score his right foot as a 1. Okay. If we turn around, the last assessment that I've done in here, actually second last, is the navicular height test. So this gives us a look at the midfoot height and positioning. So we'd have him seated with the leg in a 90-degree position. I've taken a mark here which is at the head of the navicular, okay, so we can palpate to feel that area. Across here we've done, this is the right foot, so I want to make sure that I had a problem with this morning. My left and rights were all over the place, so this is the left foot, isn't it? Okay. So we want to draw a line to the centre of that spot. We do exactly the same with the right foot here. Now between 6 and 8 millimetres is normal. Anything above that is excessive, so stand up for me. Thank you, sir. Okay, so let's do the right foot first.
That's the left knee.
Left foot first. Geez, my brain mustn't be working too well today. Okay. Iggy's a good example here. Okay. Got both of those two done. We want to measure the gap difference between the two. So if we measure the right foot here, we're looking at around about 5 millimetres. And the left foot is about 9 millimetres. So there's a difference again between the left and the right foot in both of these here. So we'd score one as a 0 and the other as a 1, which would certainly give us the navicular drop height assessment as such. So again, we're looking for how much mobility we've got through the midfoot. You would expect in someone with a relatively high arch profile that they wouldn't have much movement through that area at all. Foot generally just doesn't collapse underneath weight bearing. So whereas for Iggy's feet, which are quite excessively pronated and also collapsed in the midfoot, when I'm looking at his feet, there's probably more motion and movement coming from the midfoot than there is from the rear foot. So I'm starting to think in terms of an orthotic device, something like the higher arch contour product. Jack's test, which is the last examination, which we again have him standing in a rested calcaneal position. I generally will suggest we actually have the knees slightly flexed because we're looking at assessing the foot as if we're about to take our next step. So we want to see how much motion we've got available through the big toe to be able to progress over the top of the foot. So in this position here, we want to make sure that we're actually assessing the hallux itself and not the IP joint. So we want to just take our hand back. In terms of the amount of force that we want to use, it's the same amount of force that we would use to take our wrist to end range. So just push your thumb until it gets to end range. So it's a moderate amount of force. And we just want to see whether we can get any movement through that area. Now Iggy's big toe is pretty much fixed to the ground on both sides. So if we externally rotate again, just to give us a reference point back to neutral, we should see that that unloads quite effectively. Okay? So again, we'd score him as a 1 in that area. From an orthotic perspective, if we put an orthotic device underneath the foot, we should see some improvement. I like to use the Jack's test. I think it's a really good test to be able to use to be able to see whether there's improvement that's going to occur with the orthotic device itself. It's hard to see things from an in-shoe perspective, so using this can at least show that we've